Hi, good afternoon to you all, and many thanks for the introduction, and thank you, the organizers, for the invitation to talk here. I'm a psychopharmacologist from Brazil. Most of you probably don't know me. My main contribution to the field so far was the identification of the endogenous mechanism of allosteric modulation at CB1 receptor. But today, I dare to come here to talk about a meta-analysis study I did on the potential benefits of CBD for epilepsy, bringing together all the viable clinical data. And I think it's appropriate to express my conflict of interest because I recently accept a new challenge in life. So I'm leading product development as a scientific director in Entourage Phytolab. Entourage is a startup pharmaceutical company who is starting to develop cannabis-based products, starting from varieties of Bedrocan in Brazil. So we are the exclusive partners of Bedrocan in Brazil. And as I said, today I'm going to talk about these meta-analysis studies of CBD on epilepsy. This whole field is being pushed by stories like this one that you know, Charlotte Fish, a small child with treatment-resistant epilepsy who started to take and benefit from cannabis-based treatments. And there are many other stories like hers. In Brazil, we also have our Charlotte Fiji. So she's called Annie Fisher, is pictured here with her family. And by starting taking these products, in particular high CBD varieties of cannabis, she went from 64 convulsions per week to zero, as his dad, Norberto Fischer, is saying in this picture. And this is the patient zero in Brazil. And she was the first patient to receive the authorization to import cannabis-based products in Brazil. And from there on, there's a lot of other patients starting to import these products. I'm saying import because they're not a single registered product on Brazil right now for these children. Of course, there is Sativex, which was recently registered, but it's not viable yet in the pharmacies. And of course, Sativex is not the best option for these children. But right now, we have over 2,000 people being able to import cannabis-based products in Brazil, and the vast majority of them are epileptic patients. I would say close to 70%, and they have a lot of products available, but it's quite confusing at this time. The patients don't know how to choose. They're pressing the clinicians. The doctors don't know exactly what is the difference between the products, and the fact that these products are not standardized, and these FDA warning letters saying that they might contain contaminants, herbicides, and we cannot trust in the levels of cannabinoids that they express in the labels don't help at all. So this is the gap we want to fill with the Bedrocan varieties and proper pharmaceutical development in Entourage Phytolab. And what's the behavior of Brazilian clinicians right now? They like to say there's not enough evidence. This is very comfortable, isn't it? Like a patient is pressuring you. There's a lot of clinical reports, study reports, case reports as we saw this morning. But the physicians are saying there's not enough evidence. They're sitting there comfortably in the chair. And we rely on just a few pioneers. It's really just a handful or two of Brazilian clinicians who are starting to prescribe. I'd like to name here Paula D'Austella, which is in the audience, one of the pioneers, treating over 100 patients with this kind of products. And really, I mean, people, no matter what we do, people are starting to take these products. And do they work? I absolutely agree. We don't know exactly, especially because when it comes to herbal products, they are not standardized. So it's really hard to raise evidence using these products. But so far, we do have some evidence, and that's what I propose to do. I search for a child together with epilepsy and cannabis, cannabinoids, cannabidiol, all sorts of things to do a systematic review. And the idea was to really dig into this data and see whether there is any coherence between them. And I could find 6 papers in the first search. And I had another one by hand, which was impressed at the time, and of course, a few data from the partial public reports of GW. So this is the viable clinical data that I included in the systematic review. You can see they're all respected neurology centers, mostly from US, and they're different designs. You'll see surveys, you'll see retrospective and prospective medical records, some with a lot of patients, some not, and different durations of treatment. I'm gonna summarize in the next slides. So the characteristics of these studies are children and adolescents with treatment-resistant epilepsy, most of them with epileptic encephalopathy, including Dravet and Lennox-Gastaut, which is very important in this case. And in many, many cases, patients tried at least 4 different treatments, but up to 12 different treatments before trying CBD oil. So it's a very treatment-resistant population, so to speak. And it's summed up to 442 patients, so it's a lot of evidence, with an average treatment duration of half a year. And the products are either CBD-rich extracts or purified CBD, with a wide dose range, which always intriguing me. Like when we talk to the patients and the clinicians who are supporting the patients, the majority of the cases are in the low dose range, 1 maybe to 5 milligrams per kilo per day, but that's in clear contrast to what we see in the clinical trials reported so far. So this is something I wanted to understand using this data. So my main objective is the systematic review was to understand whether there was any consistent evidence of efficacy and safety, but also try to understand whether there were difference between people using CBD-rich extracts and purified CBD. Of course, you know that cannabis phytocomplex has a lot of different compounds. Just to mention the potential anti-epileptic compounds, we have, of course, CBD, and the obvious thing, THC is also anti-epileptic. It's even more potent than CBD, but of course it has more restrict therapeutic window. And also we have THCV, CBDV, CBN, and also non-cannabinoid compounds like linalool and myrcene. This is the table that summarizes the efficacy results. It's quite complex. Just wanted to show that there are different efficacy rates and different in different studies, and all of them are complete. So that's why you see the numbers fluctuating in the next slide. But I'm going to summarize it and make it very visual to be easier to understand. So first things first, there was clear evidence of efficacy in a treatment-resistant population. So when asked, did the treatment improve the seizures, 66% of the patients or the parents said yes, there was improvement. So 66%. If you consider the traditional threshold of improving more than 50% to be considered a responder, then this number is down to 35%. So let's say 1/3 of people are considered responders when taking CBD-based medicines, which is still a lot. I mean, remember that we're talking about treatment-resistant population, and 1 in every 3 patients are benefiting from that in a very rigorous clinical threshold. There are evidence of superior efficacy in this particular population, in Dravet syndrome, compared to the general population, not for Lennox-Gastaut, at least in this cohort, in this population. And here come the more surprising things for me. When we split between the purified CBD and CBD-based extracts, there are a higher rate of improvement in herbal CBD, as I nicknamed here in the slides, just to make it easier. There are a higher improvement here than on purified CBD. This doesn't hold true when you consider just the responders. They're both high, so 40%, but there's no difference in this case when you consider just people that achieve more than 50% of improvement. And here comes the more striking thing, at least for me. The average dose reported by people taking purified CBD is close to 20 milligrams per kilogram per day, whereas people taking CBD-based extracts report an average dose of 7 milligrams per kilogram per day. It's quite striking, isn't it? It's 3 times difference. So for me, it means that there's something else in these extracts which are cooperating for the CBD effects. So we would say that CBD is more potent when given in phytoextracts than purified. Of course, there are adverse events reported. They quite often overlap with efficacy, so it's close to 0.5% of people report efficacy, but they also report adverse event, most of them mild, just a small fraction of people report severe adverse events, and the most common ones is appetite alteration, somnolence, gastrointestinal pain or diarrhea, alterations in weight, fatigue, and nausea, and rare and uncommon adverse events also happen, but most of the time in combination with other drugs, valproic acid and clobazam as highlights. When I did this split in data for mild adverse events, there's also this difference, a higher report of mild adverse events in purified CBD than on CBD-based extracts, and this is also true for severe adverse events, a higher report for purified CBD than herbal CBD. And of course, it's important to mention this is all the adverse events which were reported. They're not necessarily attributed directly to the drug. That's a highlight from one of the studies describing over 100 patients, but I think it's a very important one to be made, is that the profile of adverse events was already very high when people were taking the anticonvulsant medicines before CBD, and most of them, almost all, went down when CBD was included. Just 2 of them went up, which is weight gain and increased appetite, which is not exactly a bad adverse event, is considered a beneficial one in some populations, for instance, oncological patients. And last but not least, other aspects that are improved by CBD, aspects of quality of life, even despite efficacy in some cases. People report improvements in alertness, sleep, humor, behavior, language, and motor skills, stating that the cognitive development of these children is being improved by the drug. To conclude, so I would say yes, there are evidence CBD works for epilepsy, at least as far as this observational clinical data in treatment-resistant population is concerned. Extract composition here is very, very key, so one must understand what kind of cannabis strain, what is the stability of the compounds. Quality controls must improve a lot in these products, and CBD-rich extracts seems to be a better choice over purified CBD, at least in this population, in these meta-analysis studies. Here's my contact for those who are interested to extend this conversation, and I would say that, of course, we will benefit for controlled clinical trials, but not enough evidence is not a reasonable excuse anymore to prevent patients from having access to these medicines. Thank you.